Thank you so much, Hunter, for braving the traffic across Massachusetts and joining us today.
Thank you. Mhm. Buen día. Can you hear me? Yes. Buenos días. Good morning. Good to see you. There wasn't a lot of traffic, but still, I'm coming from Western Mass, and I am not the morning person. And when I woke up, it was dark on a Saturday. But I appreciate the opportunity to be here. I want to start by thanking the organizing committee for the invitation to the conference. Special thanks to Maria Quinn for reaching out and asking if I could say a few words here today. I'm going to talk about recovery capital and eliminating disparities and grounding that in equity. And I would be remiss if I don't mention that I appreciate the opportunity to say these words here, because in many places and spaces across the country, we're just not able to say these things. And in some of the meetings here in Massachusetts as well. They have nothing to disclose here by way of current or potential conflicts of interest. Just want to say that. Let me tell you a little bit about myself. I have worked in the field of health and human services. In December, it'll be 38 years. I worked in inpatient settings, outpatient settings, not-for-profit settings, most of my professional career. I am a consultant on a number of federally funded initiatives, and I've been a consultant with HRSA, CDC, SAMHSA for over 2 decades. And I've worked in every single state except the state of Alaska and every single territory except the territory of Guam. So if anybody's from Alaska, I'm interested and willing to go. And Guam, I have some stuff in the works there. Why you're seeing this picture? Because I'm certified as a prevention specialist. I'm certified and licensed as an addictions counselor. And I also have a PhD. And I brought the picture so that you can see that I had long hair and that I walked in my graduation. But I also need for people to understand that I have a GED. And my GED I earned in prison. And it was more difficult to earn a GED in prison than a PhD out here. I am also a person in long-term recovery, which for me means the following. I haven't had to use an illicit drug or alcohol for the last, in December 20th of this year, to be 39 years. Thank you. Thank you. That enables me to be a productive member of my familia, first and foremost, to be present with you here today, to be a lifelong learner, and to hopefully make a contribution in people's lives, as many people have made a contribution in mine. There are thousands of people behind me that you don't see because I have done nothing on my own. And the information that I'll share with you today is not original thought either. I don't go to places to say, well, this is me, and all kudos to me and what I have done. I believe that as we do this work, we have failed to look at what history has taught us as a field. And if we don't look back, we continue to make mistakes moving forward. And at this historical point in time in the country, it is important to pay attention to history. And it is important to ground strategies, techniques, ways of doing things in ways that center history so that we don't repeat mistakes of the past. So I'm sure you've been to the conferences and meetings where people yell out and say in conversation or from presentations that addiction and mental health don't discriminate. And I am one of those people who don't sit in the front. Kudos to people in the back. I'm always sitting in the back. But I don't clap at this because that's too simplistic. It's too superficial for me. I understand that substance use and mental health can impact anybody from any class, but it doesn't impact people the same. And I think we lose something when we just with a blanket statement saying addiction and mental health don't discriminate. I'll give you an example of this, but I first want to preface the example by saying that individuals discriminate. And I have been on the giving end and on the receiving end of discrimination my entire life. On the giving end and on the receiving end, there has to be some ownership there. I can't point fingers in that direction and not look at my own behaviors over 39 years of experience. Systems discriminate, and systems are designed, policies, procedures, ways of doing things, and individuals who participate in those systems. And we have historically developed policies that push some people out while allowing some people to get in to care. And that has been very deliberate. Our system, by and large, has primarily been designed to meet the needs and to have accessibility for white heterosexual affluent males. That has been the design of the system. And if we don't believe that to be true, think about this. In the area that we're at, maybe hypothetically, there's 2,000 residential beds for people with mental health or substance use disorders. A question is, can white heterosexual males access those 2,000 beds? The answer to that is yes. Do we have enough beds for all white heterosexual males? No, and we can keep multiple thoughts in our head, right? Now, if the person identifies as female, can they get in? It's more difficult, not to the same degree as the other population that I was talking about. Let's add some caveats. Now that female has kids, can they get in? It's more difficult. That female has kids, doesn't speak English, more difficult. That female doesn't speak English, has kids, doesn't have health insurance. That same female with all of those characteristics doesn't have documentation to be in the country. What happens? So this mantra, addiction and mental health don't discriminate, our systems do, and they're designed that way, and they're very effective of doing that. If you identify as LGBTQ+, can you get in? It's more difficult. If you identify as an older person, our system wasn't designed for older people. If you are a younger person, it wasn't designed for younger people. If you're a person with disabilities, cognitive or physical, wasn't designed for people with disabilities primarily. If you're from the deaf community, can you get in? If you are from the blind community, can you get in? See all those caveats? It is way more difficult, and we should not be simplistic. We should not sit back and say we treat everybody and we meet people where they're at. That's a load of crap. Forgive the language early in the morning. It is. It is a load of crap. The other thing that we have done is we have developed and sustained silos all over the country and here in Massachusetts, in a state that is a service-rich state, right? If you think about it, someone comes into a place of service because they have a substance use disorder and they have a co-occurring mental health issues. In many places, they don't know how to treat it, and we need to send you somewhere else. If you need medical services, I need to send you somewhere else. If you need health and human services, housing, food, clothing, whatever that, I need to send you somewhere else. Employment, I need to send you somewhere else. Most of the folks have been touched by child welfare systems that are designed very specifically. I need to send you somewhere else. And so what happens to our folks is you walked into this room, we walked into this room as holistic beings, not fragments of who we are. And this is what we say, pay attention to the rhetoric. Oh, they fell through the cracks. We're blaming people for a system that doesn't have cracks. It has gaping holes that were designed by policy. Many of these silos are sustained by funding sources that say you must collaborate, but you must compete. I'll fund you to do this, but you can't do that. That is by design. When I say you fell through the cracks, it means that you fell. It's your fault. Right? We design gaping holes for people, depending on who they are, what they look like, the texture of their hair, their accent, how they speak, their last name. their gender identity, all of that stuff. We have designed things to make it difficult for people. I wish it ended there, but our system has a history of punitive approaches. Up until recently, there was a lot of funding coming into our field. Because of the federal changes, we have seen what's happening with funding and who's getting access and who's not. But even then, when we were getting a lot of money into our field, it wasn't enough. But we know what's needed, but we refuse to fund what's needed. We have a policy written in some places and unwritten in others that if people experience signs and symptoms of their disease, we're going to make it more difficult for you to be in care. And in some spaces and places, we kick people out for recurrence, for a return to use, for exhibiting signs and symptoms of the disease that we, as professionals and the organizations that we represent, have said that we know how to treat that and that we have the qualified staff. Imagine if you have diabetes and you were out there eating stuff that you weren't supposed to, and your blood sugar level gets out of control, and you call your doctor's office. The doctor's office is not going to say, call back in 2 hours, call back in 2 hours, call back in 2 hours. They're going to schedule an appointment. They're going to draw blood. They want to see if it's medication, exercise, diet, or a combination of the three. The thing that's not going to come out of their mouth is, we're taking your insulin because you have been irresponsible with the cookies in the hallway. If they did that, it would be malpractice, there would be a lawsuit, and people would win. In our field, as we speak right now, this early on a Saturday, someone is being kicked out of care, pushed out of care, treated indifferently because they have been there 2 or 3 times, because they have an accent, because of the texture of their hair, because of the pigmentation of their skin, because of gender issues, because of a whole host of issues. And if we don't own that, we will repeat that. And some of us don't like to hear that. And some of us have been on the receiving end of that, and some of us have been on the giving end of that. I believe that people are in this field because we want to help other people. But the reality on the ground for many people is that we push people out. Punitive approaches. We have led with a criminal injustice approach to a public health matter across the country. That's just a reality. Doesn't end there. We have criminalized color. When we look at the data of who's behind the wall, we see Native, Black, African American, Hispanic, Latino, Latina people disproportionately represented amongst that population. Over 90% of the people that we serve have been touched and impacted by that criminal injustice system. And notice how I call it. You can call it what you want, but the reality of the data do not lie. How many of you believe that we have an opioid crisis in the country? After decades and decades and decades and more decades of people dying, why declare a crisis in recent history? Anybody? You heard those chuckles? You heard that? I've been asking, the people who know me in this room know that I have been asking this question for over a decade. When I first asked it, no one would say anything and no one would dare laugh. And what I got was nasty looks and people coming up to me and say, how dare you? How dare you say that? Here in Massachusetts, by the way. There has been a little bit of evolution and a recognition that is because young, white, affluent kids began to die at alarming rates. And this is what I will always say about that. They deserve prevention, intervention, the multiple pathways of recovery and recovery supports. And so does everybody else, damn it. Not just one segment of the population. And I don't believe that we have an opioid crisis. And now you're probably saying, oh shit, what does he mean? Forgive the academic language this early in the morning. Why? Because our crisis is way more complicated than just opioids, you see? We have a crisis in substance use disorders, plural, not singular. Over 180,000 people died last year of alcohol-related disease. That surpasses opioids Over 400,000 people die each year of tobacco use, and people die of methamphetamine use, of cocaine use, and yes, opioids, and I don't want to minimize that. I buried my sister, my aunt, 3 cousins, and a whole bunch of friends and colleagues. I don't minimize that. This for me is not an intellectual exercise. And for many of us, like the letter from the good doctor, outgoing president, right? Very personal connection to this stuff. We know people we put into the ground. We have a crisis in criminalizing people. We have a crisis in education. We have a crisis in this child welfare system that we call, that is supposed to be just, that removes people for having, removes kids because their parents are struggling with substance use and mental health issues. And by the way, removes kids of color at a greater clip than their white counterparts. That's a reality in the data. We have a crisis in housing. We have a crisis with gambling that we don't want to talk about. I understand there's going to be a little workshop later on today on gambling. Hope that people go to it. Now we have sports betting in the house, and we have had gambling in the state for a very long time. And people think about the 2 casinos that we have and the most profitable per capita lottery in the world that pulls in over $1 billion. Who do you think plays the lottery? That is primarily poor people. That is primarily poor people, right? Because people who understand the odds and are affluent, have money, they know what that looks like, right? So our crisis is way more complicated than what we think and what we assume. When we have myopic views of what the problems are, we will always come up with myopic solutions that sustain the status quo. Pay attention to what's happening now in the country with opioid overdose deaths. 2023, 10% reduction. 2024, about a 24% reduction. General population. And you know what happens? Many people are patting themselves on the back and saying, this is a great thing. I am not celebrating the fact that opioid overdose deaths have shot up for Native people, for Black and brown people, for Latino people, for African-American people, while it has gone down for the rest of the population. And you see why I disagree with celebrating the status quo, because we thought that the crisis is because young white kids are dying, and we take all people's tax dollars, we channel them to certain communities while other communities get what? Prisons, jails, punitive approaches. This is why history is important. This is why having this conversation is important. We know all about disparities, right? I'm preaching to the choir here in many senses, but disparities exist. There's disproportionate impact depending on the communities that we're talking about, right? And up until recently, there was a webpage on Healthy People 2030 that talked about all of this stuff, and it's taken down. It doesn't mean that disparities have gone away. And we have a responsibility to lead in all facets of this endeavor. It is not the social determinants of health. We're actually talking about the structural determinants of health. I refuse to say the social determinants of health. You know why? Because that's too wishy-washy. The social, it happens socially. No, structurally. Structures are built with policies, procedures, and people doing things in very specific ways to sustain the status quo. And what are we talking about? Healthcare and healthcare access. What are we talking about there? Home, vivienda, place to live that's recovery conducive, that is safe within the community. Income, employment. Pay attention to what the rhetoric is in the news right now. 4% unemployment rate, the lowest it's been in 50 years. Yay, yay, yay. Really? For who? Take a look at the disparities data within that, and you'll see that the unemployment rate for Native Americans is closer to 20%, that the unemployment rate for African Americans is above 15%, and in some communities even higher, that the unemployment rate for Hispanic, Latino, Latinx communities is around 13%, and in some spaces and places even higher, that the unemployment rate for people who have a criminal offender record like the one that I have is effectively 27% in the country. And so we should not celebrate things that people tell us that we should celebrate without having some level of critical thinking and doing a deeper dive in what those things look like in people's lives. in the neighborhood conditions. I understand that Massachusetts is the second healthiest state in the country. I live in Hampden County. That is the unhealthiest county in Massachusetts. And I live in Springfield, in the north end of Springfield, where we have some of the highest asthma rates in the country. So if we don't look at what's happening there, where the 91 overpass cut that neighborhood in half to begin with, that we have the largest provider, which is Bay State Hospital, that has maybe 10,000 people per shift, 3 shifts, do the math. How many cars drive into the north end of Springfield? When I grew up in the north end of Springfield, everything from the exit, from exit 8, you turn left, was housing and places where people worked. Right now, all of that is parking and high-end medical services where people of the north end don't have access. And by the way, less than 3% of the people from the north end work there. And it's a self-contained environment where people are told officially or unofficially, don't go to the north end, that's dangerous. These are built environments, the structural determinants of how determine who gets access to what and what quality of care looks like. And by the way, it's not just about access, it's quality of care. I have health insurance and I've been treated like crap in spaces and places where I've entered. So just having health insurance doesn't guarantee that we're going to be treated correctly. Some people get really upset when I talk about these things. And my answer to that is good. Nothing has ever changed unless people get upset. So he went from that to a big old elephant's ass. And he continues with the academic terminology. I refuse to go anywhere in the world, including here in the US, and not address the elephant in the room. And that is a couple of things. The school to prison pipeline. We have policies that were developed, and this coincides with the 1994 largest crime bill that was signed into law by Bill Clinton regarding schools. Militarization of schools, policing in schools, metal detectors, all of these things that are happening within schools, and not addressing the root causes. Young Black and brown kids are tracked into juvenile justice systems that then will track them into prisons and jails. And their white counterparts are not suspended or tracked in the same way for the same level of infractions. This is a huge thing that's happening within communities. I am not a high school dropout. I didn't drop out of anything. I was pushed out of middle school. And right now we call those, when we say dropout means what? You dropped out because you are responsible. You did that to yourself. But we have policies and procedures that push young people out, that treat people badly, that criminalize people. I presented at a conference in Connecticut right before the pandemic. Guess how young the youngest person in Connecticut is on probation at that time? Anybody? Yeah, that reaction. Young Latino boy, the probation officer, it was 200 probation officers. The probation officer was in the room. I said, what did he do? Said he brought matches into the school. And he lit a couple of papers on fire. And so because of zero tolerance policies, the teacher needs to tell the principal needs to call the police needs to do something about it. He's charged with arson. And then he ends up on probation. And the probation officer, I said, so what do you do with him? He says, I don't know. I sit with him and I play games while his parents sit in the hallway. We went from 200,000 people incarcerated in the US to 2.3 million in a span of a few decades. We have 5 to 6 million people on probation, parole, house arrest. We cannot talk about substance use disorders without talking about this stuff. I see you and I hear you, brother, and I agree with you 100%. Each year, we release 7 million people from county jails. Each year, we release approximately 600,000 people from federal and state prisons. The majority of them, upwards of 97%, are poor. Disproportionately Black, African-American, Native people, Hispanic, Latino people. The majority of them have co-occurring issues, not just mental health and substance use. Upwards of 65% have a diagnosable mental health issue. Upwards of 80% have a substance use issue. Those are huge numbers. The largest provider of mental health services in the country are prisons and jails. If you have a mental health condition for one of your loved ones, where is it that you want to get it treated? At a prison or a jail? I know plenty of people who work in prisons and jails, and they do their best to humanize and to treat our folks. But not everybody gets access to that treatment. Not everybody gets access to care in the way that they should. This is a huge injustice. We have the largest prison population per capita in the world. This is the time to be yelling USA number one, USA number one, USA number one. This is what we have built. And right now, prisons and jails across the country are rebranding themselves as treatment facilities. Do you really need to go in jail to get access to treatment? Do we really need to continue to do that? To force certain segments of the population into that process? There's policies, again, the built environment that drive mass incarceration. Anybody care to yell one out? 3 strikes and you're out. Thank you for that. Anybody else? Different policy. War on drugs. Anybody else? Bail. Thank you. Let me give you the long list. I'll try to do this quickly, right, in the interest of time. Deinstitutionalization, 1960, then President Kennedy signed into law a bill that said we're going to do 2 things. We're going to close down all state mental institutions that were called at the time. The second part was influenced by his mom, Eunice Kennedy, who said, we're going to reintegrate people back into the community. The first part of it happened. The second part did not. Many people ended up in prisons and jails. The war on drugs, Tricky Dick, I like to say his name, 1970 policy. We're going to go after people who use drugs, possess drugs, who sell drugs in a very hard way. That policy is alive and well today. Criminalization of behaviors. This grows out of the Rockefeller laws in New York State. And we criminalize people. What was Brother Gardner doing in New York when he was choked to death by the New York City police? He was selling loose cigarettes. At some point, that wasn't illegal. But we criminalize certain things, including poverty. In their infinite wisdom, the US Supreme Court last summer, what did they decide? That we can criminalize homeless encampments. That's criminalizing poverty. And that is giving the okay to cities and towns all across the country and here in Massachusetts to criminalize people who live in a park or on the side of a river. We're trying to criminalize panhandling as we speak across the country. And the list goes on. Powder versus crack cocaine, 1994, the largest crime bill in US history, thanks to Bill Clinton and the rest of the people who voted for all of that madness, right? 100 years to 1, disparities in sentencing. Obama brought it down to 18 years to 1. I know I have people who are still doing time, 20, 30, 40 years for small amounts of crack cocaine, while people who got away with having a lot of powder. Why? Because of the money interest here. Mandatory minimums, 5, 10, 15, 20 years behind the wall without the right to probation, parole, or get reentry services. No voting rights in upwards of 20 states. If I move to one of those states, I can't vote for things that I did over four decades ago. I'm still paying the price, and people like me are still paying the price. This sustains stigma in a huge way. Bail. If you look at what bail looks like for people, most people sit behind the wall waiting because they can't afford bail because they're poor. And the bail system is a profit mechanism for some. Fines, perpetual fines. I was in Alabama recently, and during the lunch break, I went out with a couple of colleagues to get something to eat. It was a beautiful restored theater and we were walking by it, and there was this black gentleman sleeping in front of the theater. Two police officers showed up on bikes, and we said, good, they're gonna do something about it, because they stopped. One of them made him get up, while the other one wrote the ticket and said, you need to move. That ticket, do you think is gonna be paid? The person is experiencing homelessness and is poor, obviously. That person will end up in jail because of that ticket and that fine will continue to go up and up and up and up and up and up. This is what we do. School zones. In the city where I live, only 1,000 feet is not a school zone. School zones is 2 years of mandatory time attached to the sentence. 1,000 feet is not a school zone. That was designed for inner city. The majority of people who live in the inner city are people of color, and that was designed to impact people in inner city. 3 strikes and you're out. Thank you for that. Earlier, there's a guy in Texas right now doing life in prison. His 3rd strike, he stole 2 slices of pizza. There's a guy in California who broke into a soup kitchen. My friend here and colleague who worked in our field for 7 years had a recurrence, and he got life in prison for a stolen car. I don't know about you, and I'm not Pollyanna. I did some shit that I need to go to prison for. But really, life in prison for being hungry and stealing 2 slices of pizza, for stealing a car? There's thousands of these cases across the country. Massive prison construction. You don't go from 200,000 to 2.3 without building prisons. Think about who profited from that. The people who put together the supplies for building the prisons, the contractors who got the contracts to build the prisons, the maintenance contracts that maintain those prisons. And by the way, most prisons in Massachusetts are in white, affluent neighborhoods. The majority of people who work in them are white. Those are really good salaries. Those people vote, and they don't vote against their own interests. And these prisons have put their kids through school with retirement accounts and health insurance for the rest of their lives. And if you're sitting in this room, and I hope you have a 401k or 403b, you probably have money in private prisons and jails, because they're traded on the New York Stock Exchange. We monetize everything in a capitalist society, and in this society even more. From the commissary to the food that people eat, to the clothing that they wear, to phone calls. You know what phone calls do for people who are incarcerated? Connection to family, increase reentry, decrease isolation and depression. They do all of those things. Yet we monetize that. And it doesn't have to be a private prison and jail. All prisons and jails in Massachusetts will charge you for video calls, for emails, and for phone calls. And it costs on average $300 to $500 a month for a poor family to accept phone calls for someone who's incarcerated. Think about that for a moment. And then criminal offender records. What does that do for people like me, for people in early recovery, for people seeking and needing support and humanization? It makes it more difficult for people to get housing. Structural determinant of health. Makes it more difficult for people to get employment. Structural determinant of health. It makes it more difficult for people to get their kids back if they were extracted by the system. And by the way, that system takes your kids really quickly, doesn't give you any resources, but puts your kids in another place that they provide resources to that place. And then they tell you, you need to jump through all of these hoops to be able to get your kids back. This is what this is designed to do. And there are others. Let me give you some additional data. Have you heard of plea bargains? 97% of all cases at the federal level are pled out. 94% at the state level are pled out. What that looks like is this: the 4 of us are in the bullpen, waiting to be sentenced or waiting for trial. Why are we in a bullpen? Because we're poor. Our lawyer comes out. Who's our lawyer? A public defender. Who, by the way, many in Massachusetts recently stopped working because of pay issues and all of that. They have 150, 200 people on their caseload. So they come to the bullpen. 3rd strike. They want life. Are you willing to take 20? They want 20. Are you willing to take 15? They want 15. Are you willing to take 10? They want 5. Are you willing to take 2? The majority of us are going to say yes to that because we know that if we take it to trial, we're going to be smoked. Because the DA is an elected official. They don't want to be viewed as soft on crime, and they're worried about reelection. That's the system that we have built. And this is passed off when you hear scholars talk about the greatest legal history in the greatest legal system in the history of the world. I have a question for you. Raise your hand if you think this is broken. Some of you are going, hell no, it's not. Because it's not. Because it is not. This system, I described deliberate policies. These are not policies who fell from the sky. These are not policies by coincidence. The people who worked on these policies knew exactly what they were doing, and they produced hundreds of billions of dollars in profit. If we dismantle the system today, the economy would collapse. Some of us in this room get paid because of this system. Judges, lawyers, DA's offices, the construction companies, the people who work at, it's all tied in together. All of it is. This is not broken. I was in an echo call this week with people who are working with folks behind the wall. There's something that we do here in Massachusetts and all over the country that all of the other developed countries don't do, and that's solitary confinement. That is considered torture. But we have people 5, 10, 20, 30, 40, 50 years in solitary confinement without thinking about what that looks like. Back to that situation that I was in, providing some guidance and some input. The person refuses to talk to anybody. The person is autistic. He's verbal, but he stopped talking to the people in the jail, and he refuses treatment. And they have him in solitary confinement. If you think about what that looks like by way of humanizing or dehumanizing people, imagine being that person. Imagine sitting behind that wall for that many years. And I know people have done 5, 10, 15, 20 years in solitary confinement. I myself experienced 6 months of that. You experienced a little bit of solitary confinement. Remember COVID? How many of us were sent home and we were working from home? Were all our mental health impacted? Of course it was. But there I sat with my TV, with my computer, with my internet, with the refrigerator, with money coming into my account, with contact with other people via social media. There I sat with all of that. Imagine not having any of that. That's what we've created. So impacts and outcomes. The institutionalization of folks. How many people have seen Shawshank Redemption? If you haven't, it's a really good movie. You should watch it. Right? The person up top, what did he do when he was released? He hung himself. He killed himself. He couldn't be outside. If I had more time, I would give you some examples of what this looks like for people. This drives stigma and discrimination. This drives our insistence that we pull ourselves up by the bootstraps and that all it takes is personal responsibility. And I am asked to go to many places and say this: I have a PhD, I have a GED, and I got it in prison. And if I did it, anybody can do it. And when they ask me to do that, I go, I'm not doing that. You crazy? I'm not saying that. Not because I don't believe that anyone can get a PhD. I think that people have the capacity to get it. You put hard work into it, you can get a PhD. But the system wasn't designed for everybody to get a PhD. It wasn't designed that way. I am an outlier. I am not the norm. I wish it was, but it's not. Right? Have you heard the people who say I'm non-biased? I used to say this a great deal. I don't say it anymore. Have you heard the people who say I'm non-judgmental? I used to say this a great deal. I don't say it anymore. Have you heard the people who say I treat people the way I want to be treated, or treat people the way they want to be treated? I used to say these things. I don't say them anymore. And my personal favorite is when people go around saying, I treat everybody the same. And then they pepper it with, I don't see color. You don't see what? I don't see color. I don't see color. You've mentioned it 3 times. I don't see gender. Really? Because as soon as I walked into this place, that's the first thing that I had to work with. Are you male? Do you look female? Other? Are you white? Are you black? Do I perceive you to be Hispanic, Latino, Latina? All of those things. Everybody here did that. This is all a huge crock of shit, by the way. Are we biased? Of course we are. We're not born biased, but we learn biased family, places of worship, school, media, social media. You're learning bias now. I love it when I go into places, people say, well, this is my objective opinion, or this is my, this is what research says. Really, who designed the research? Who designed the questions? Who did this? Who did that? Who did that? When we get to those very specific questions, we'll see how we can drive research to say what we want it to say. So are we judgmental? If you're sitting in this room and you're saying, no, not me, but you are, because as soon as you open your mouth, you start to judge systems and individuals and well, welcome to the crowd. That is a judgment. And if you agree with me, it's a judgment. If you disagree with me, it's a judgment. We judge. When we combine judgment and bias, that's a recipe for disaster. How many 60-year-old Puerto Rican males in the room? Raise your hand. Donde están? I have no business treating you the way that I want to be treated. And even if this room was filled with 60-year-old Puerto Rican males, we are not all the same. And you are different from you, or different from you, or different from you, or different from you. I have no business treating people the same. I need to individualize my interactions based on who you are and what you present with, and what are you willing to do? Not what I want you to do, but what are you interested in willing to do? The bottom line is we should individualize our interactions with folks, and we should treat everybody with dignity and respect. In the time that I have left, I want to talk a little bit about strategies and policies and that sort of thing. Our language matters. We're getting better at this, but still, we're not quite there. Let us stop thinking that we work with broken people. I don't work with broken people. And I am not here to save anybody's lives, because I don't have the power to do that. The only time that I've saved someone's life is I administered Narcan and a few people were dying from an opioid overdose. Other than that, I walk side by side people. I share information, resources. I'm a cheerleader. They take control over their lives and they save their own lives. This whole idea of I'm here because I want to save lives. I'm like, eso no trabaja. If we want to view people as broken, go ahead and do that. But it doesn't work, right? People have resiliency, strengths. Some of them have been in conditions that some of us would not last one day, never mind 5, 10, 15, 20 years behind the wall, never mind in solitary confinement, never mind in other conditions that are deplorable to human beings. So what is recovery capital? When we think about all of this stuff that I talked about by way of barriers and that sort of thing, how do we encourage people to develop recovery capital, and how do we actually do that in practice? It is the internal breadth of knowledge, right, and external that people use to support their recovery. When we talk about physical recovery capital, we're talking about physical health, we're talking about employment and income, we're talking about health insurance, clothing, safe and recovery conducive place to live, food, transportation, and others. We can influence and impact recovery capital on folk. These are connected very closely to the structural determinants of health. There's another type of recovery capital, which is called human recovery capital. If you haven't read William White, I encourage you to read William White, one of the leading researchers in the country on this stuff. He's talking about values, knowledge, education, vocational skills and credentials, problem-solving capacities, self-awareness, self-efficacy, self-esteem, hopefulness and optimism, perception of past, present, and future, sense of meaning and purpose, and interpersonal skills. We can also influence all of those. How many of you work with people who have lived experience, recovery coaches and that sort of thing? How many? All right, see, this is really good, right? I taught, co-taught the first Recovery Coach Academy here in Massachusetts over 15 years ago. And when we asked this question, most people didn't know what that was. And, I put a plug in for folks who have lived and living experience who are working in our field, but I'll also ask you to advocate on their behalf. They're the least paid, least respected, and least valued. And we need to change that because these folks help people develop external and internal recovery capital. And so does everyone else. But if we want to center their value, then we need to do something about it. It is not about cultural competency, it is about cultural humility. It's a lifelong commitment to self-evaluation and self-critique. That's as much as I'll say about that because I just got the mark that we are close to it. I can't say I want to get better and not do something about it. There's some self-assessments. I'll leave you with those in the presentation. Harvard has a really good one on implicit bias. The National Center on Cultural Competency out of Georgetown also has a number of tools that we can use. I'm going to jump over this just to say that many of you have seen this image before, and people go to the middle and say the middle is equity. It's not equity. It is a redistribution of the boxes, and it's actually blaming people for their height. All you need is boxes to be able to see the game. No, in order for people to see the game and participate in the game, we need to work on tearing down the fence. The fence represents policies and procedures that keep some people out while allowing some people in. It is a different orientation to the problem. And believe me that I chase boxes too. Because I know the clinical supervisor over here and I can call them and get somebody in. And at the end of the day, I'm supposed to feel good about that. And I don't, because they should not need me to get in. This is a structural thing. This is a structural thing. We need not to just be trauma informed. We need to be social justice informed. And I'll be damned if anyone silences me about that. First, I'll lose my job, but so what? Someone will hire me. And I have other skills. Not just about criminal justice reform. This is about leading with restorative justice. And when we think about recovery capital, and when we think about combining those things with restorative justice, what are we doing in the services that we provide that center restorative justice for people? Again, I wish we had more time. A lot of money coming into our field. Healthcare settings, criminal justice settings, community-based organizations. Most of the money going where? Criminal justice settings and healthcare settings. Not that I'm against them getting money, but who has the most trust in the community? Community-based organizations. Who has the most experience? Community-based organizations. This is an equity question. By the way, many of these healthcare settings gave us overprescribing. Criminal justice settings gave us mass incarceration with a few hours of training. Now they're rebranded. We're the experts. Yeah, but we have recovery coaches. Things to think about there. We went from abstinence for all, so you need abstinence, you need abstinence, you need abstinence, you need a lot of abstinence, you need abstinence. So what now? What's the magic bullet now? Harm reduction, I wish. You need medication, you need medication, you need medication, you need a lot of medication, you need medication. Everybody needs medication. I am not against medicated assisted treatment or medication assisted recovery or MOUD. I actually, up until recently, was a supervisor, clinical supervisor, a federally qualified health center, and that's what we did, working with a team of doctors, nurses, recovery coaches, and that sort of thing. But here's what I know, here's what we know, that all of the credible evidence indicates that there's multiple pathways of recovery or infinite pathways of recovery. There are 23 million people in the US who identify as being in recovery from a substance use disorders, and not all of them did it through medication. And so when you leave this weekend and you go into a restaurant, pay attention to what they do. They sit us down, they offer us something to drink, and then they bring out this revolutionary thing called what? Fucking menu. And they ask us, what do you want? And if you like it, you have more of it. And if you don't like it, what do? You select something else or you go somewhere else. Let us stop telling people what to do, when to do it, how to do it, and imposing our values on people and then blaming them when it doesn't work. Historically, that has not worked. So we know 12-step, medication, storytelling, celebrate recovery. Do those work? Are they for everybody? Sobriety, natural recovery, faith and recovery, recovery and exercise. Do those work? Are they for everybody? The arts and recovery, smart recovery, refuge recovery, holistic recovery. Do those work? Are they for everybody? Evidence-based, rational recovery, sound healing and recovery. Do those work? Are they for everybody? Harm reduction. Does that work? Is it for everybody? I wish we had more time. Harm reduction saves lives. For me, recovery is harm reduction. Harm reduction is recovery. How many people here practice harm reduction? The rest of you don't brush your teeth. You don't look both ways before you cross the street. You don't wear a seatbelt. You don't do any of that stuff. Harm reduction has been around for a very long time. While we argue, our people die. While we argue, our people die. Harm reduction is not condoning drug use. Harm reduction is taking into account that dead people don't recover, that change is not an event, it is a process. Then we need to take a look at what Prochaska and Di Clemente have taught us about stages of change and what that looks like. And some of us in this room right now are in pre-contemplation. Just like the people who are in pre-contemplation and they don't want to stop using. And so I don't want people to get HIV. I don't want people to get hepatitis C. I don't want people to die of an opiate overdose. So I embrace harm reduction. And I practice harm reduction on a daily basis as a person in recovery. But if we're not pushed to think in these ways, we're not. What's the most controversial thing right now about harm reduction? And there was a hearing on Monday, right, about these things here. How many of you? Yeah, so it's so safe consumption sites. I visited the ones in Portugal, and now they're rebranded as opioid overdose prevention centers. The first two in New York City, On Point, friend of mine, Sam Rivera, executive director, it's called On Point. Take a virtual tour so that you can see what it is and what it's not. How many of you have ever been into a legal safe consumption site? You people, not everybody. How many of you have been into a bar? It's bullshit, right? You hear it? The further along I get in my talk, the more it comes out. If you got a tattoo at a tattoo parlor, safe consumption site. If you have entered into a smoke shop, safe consumption site. We get all bent out of shape because it's people using drugs. Safer. Of the 2,500 people who have overdosed in that safe consumption site in New York, 0 have died. 0 have died. Of all of the safe consumption sites in the world where people have overdosed inside that space, 0 have died. Most of those people would be a different story because they would be using by themselves. And in that place, if this is the spot, 25% is for the safe consumption. The rest of it is other services that we provide. All of it. 1 minute. Current workforce, white, female, baby boomer, soon retiring. People walking through the door, younger, diverse. And so what we need is what? A more diverse workforce. And those of us in positions of power have a responsibility to bring people in, not to push people out. Not to be threatened by people who can do our jobs better than we can. I'm on my way out of this profession, at least getting paid to do it. I will always volunteer to do this work. But I know young people who can do my job better than I can and who understand things better than I do. They're not a threat to me. They shouldn't be a threat to us. This is my final slide. It's a little bit involved. Remember Katrina? Today marks the anniversary of Huracán María in Puerto Rico. We were devastated. Before that, Katrina. Remember that? Take a look. We worked really hard to pull some people out of the rivers of substance use, mental health challenges, poverty, homelessness, incarceration, etc. White people in a boat. Their pets are in the boat. People are pulling them out in the boat. Historically, racialized people have had no choice but to do for ourselves, and we have. There is no boat. There's kids in a cart being pushed out. And these are people of color. And then there are those people who are intentionally left behind because there are more profits to be extracted from trauma, poverty, and unhealthy people. And so I believe that we need to take a page out of the book of who? Desmond Tutu, who said, we need to stop just pulling people out of the river. We need to go upstream and find out why they're falling in to begin with. This is a call for prevention. If we continue just to focus on treatment and everybody needs treatment and everybody needs treatment, we continue to chase our tails. We need to do something different. How many people here work on prevention? Just a few hands went up. How many people here work with people who have kids? All of you work in prevention. Welcome to the field. Highest risk factor for a young person is to have a parent who uses substances. If you're working with their parent, you're working on prevention for that young person. That is my time. Muchas gracias.